Hello and welcome everyone for tonight's EAO Just Ask. Dear friends, summer is there, the World Cup is there, and we have a world-class expert and a world-class topic. Although Belgium is playing in half an hour, I motivated her to be there. It's Professor France Lambert. France, thank you very much for being here. It's such a pleasure that you agreed on behalf of the EAO. I don't think I need to introduce you. You're world famous in the area of implant dentistry and periodontics. You're the head of the perio and orodental and also implant department of the University of Liège in Belgium. I know you play in half an hour. I will take my time. You're also affiliated with the Biomaterials department. You are a great researcher on topics of biomaterials, socket preservation, immediate implant placement, and you are one of the speakers of our annual Congress in Lisbon from 24th to 26th of September. France, with that, a warm welcome from the EAO channel, also from the whole EAO community.
Thank you, Stefan. I mean, it's so great to be here. So happy, and indeed, it was a bit of a negotiation with my kids, because they wanted to watch the game, and we were in the same room, so I had to send them somewhere else. So, but I think at the end, I prefer to be 1 hour with all of you here talking about a very fascinating topic.
Yeah. Thank you for that. That's really great. I am a little bit relaxed because Germany played yesterday, so I'm cool. But I think you definitely will see the second half of the game. And Belgium is always one of my favorites, I would say. France, I also had to negotiate a little bit with your topic with you because I know immediate implants is your favorite topic, and you're also absolutely famous for your lectures on immediate implant placement. But I didn't want to hear about immediate implant. I wanted to hear from you, what do you do when it's not possible? So thanks for accepting that. And France, you know what happened today? A patient came in and I thought about our Just Ask this evening. It is a situation where I thought, can we go for immediate implant? It would be good, great, fast, quickly, but it doesn't look that good. I brought it for you. She has a pretty high smile line. You see it now, and everyone also sees it. I have a recession. It's a lateral incisor. We can also discuss maybe it's not an implant case, but we have perio breakdown. We have interproximal loss. So, France, what is your take? I have to go on the phone with the patient tomorrow and tell her what I'm going to do. So give me an advice.
Well, Stefan, that's true that I'm an immediate person, and as soon as I feel safe and I think it's going to be a reliable treatment for my patient, I would definitely go for it. But in your case, there is a few things that are kind of worrying for an immediate case. Of course, we definitely see that there is a recession there. There is proximal bone losses and all this already. Just that, for me, this is something I would be very careful about when considering immediate. And as you said, this is a lateral incisor. And to be honest with you, I tend to implant less and less in the lateral incisor position. If a bonded bridge would be an option, and it's often this often can be an option. But let's say that the treatment plan is to do an implant. I think, no, I'm sure this case I would delay and I would, do an alveolar ridge preservation and see and reevaluate and then define the strategy later on.
Great. Help me a little bit. If you would go for a resin bonded bridge or a ceramic bonded bridge, would you also go for a socket preservation?
Of course, of course. Yeah, because we know that the extraction will lead to shrinkage of the alveolar crest, and especially because she has a high smile line, we want to preserve the volume, alveolar ridge preservation, possibly also a connective tissue graft, and combined to the bonded zirconia bridge probably. Yeah.
Perfect. Franz, I know you have prepared some content. I know I had to make you work because it's not your regular presentation. But I'm so interested what you're gonna present to us. Where you see the border between immediate and between delayed. We had the just after Jan Kosin. I think you saw that one. He was also quite strict when it came to like the dehiscences of the bone. So I'm so much interested. And the people are listening also to you. There's Daniele De Sanctis, there's Alberto Salgado. Hi to all of them. So they want to hear your content. And Franz, I normally I interrupt at any time if there's a question. I would just interrupt you. It's not unpolite. It's just because we're all interested and want to know more about your knowledge. So please, we're looking forward to your presentation.
Yeah, sure, Stefan. I'm really happy to have a discussion. Let's talk together, and the content, of course, is uh, just a support. I mean, I don't. I'm not sure we have to go through the different implant timing, but I cannot cover everything because there are different philosophy. Of course, there is immediate, which is type 1. And then the late implant placement is when it's fully healed after 6 months. But then in between, there is the early, the delayed. Um, the approach, the typically Swiss approach of early implant placement where only soft tissues are healed and this is an incomplete bone healing, very often associated with implant placement combined to large flap and GBR. I mean, it's a very evidence-based approach, but this is not so much what I'm doing. I'm going more with a delayed approach, doing alveolar ridge preservation and placing the implants after 3 to 4 months. This is what we are going to see in the case today. But I wanted just to set up a little bit the different timing of implant placement and saying that I'm not going to talk about everything because there are different ways to do things, of course. But when I can, and I was telling you, when I'm able and when it's a good conditions, patient site, site-specific condition to do an immediate, so basically intact socket, appropriate soft tissue phenotype and no soft tissue defect. I definitely always try to go immediate because this is, first of all, less surgical procedure, less invasive for the patient, always without flap. Sometimes a connective tissue graft, but not always. And but most importantly, it's better in terms of biology in my eyes. Not only because you are less invasive, but also because you can also work with a professional crown that would support the tissues and decrease the shrinkage. And if you're not able to immediately load the implant, you can also work with anatomical abutment. But I'm not here, as you say, to talk about immediate, but you have to know that immediate now in favorable conditions, this is really, especially for the anterior maxilla, an evidence-based approach, immediate implant and immediate loading. There is now enough data about that, and I find it as a first option when it's favorable.
I have a quick question to that because you're such an expert and I want to have your knowledge a little bit also to immediate implants. You talked about like the one stage approach, meaning immediate implant and immediate provisionalization because it might be good to support the tissues. You then talked about if you're not able, you're going for an anatomical healing abutment. So how important is it in your eyes to support the soft tissues, to not put on a cover screw and let everything fall together? How important is that in your eyes?
Yeah, that's what I call the restorative driven soft tissue healing. We're talking about immediate implant, but the concept is the same for pontic, is the same for even a crown lengthening. I mean, having the ideal anatomy design, crown design guiding your soft tissue healing is for me very important. You know, during this healing phase, there is some changes, there is inflammation, but there is also like more blood vessels, more cells, and having something that really guides the healing is for me an opportunity, and it's an opportunity that we cannot miss. And I'm much more into having a proper design at the time of the surgery than doing this, what I would say, old-fashioned soft tissue conditioning.
Sculpturing,
You know,
yeah.
little by little, it takes time, but it's a different approach.
And probably you will not get the height which you could like achieve when you immediately restore it or put in an anatomical healing abutment, right?
What do you mean by the height?
The gingival height,
Yeah,
which you could preserve, right? By conditioning and sculpturing, like in a second stage.
yeah, absolutely.
Yeah, got it.
So, but when we talk about immediate implant, of course I have to mention a book I wrote a couple of years ago together with Adam Hamilton and also many very, very talented clinicians and contributors. It's I like to say it's a little bit the cooking book of immediate based on, you know, when do you do it, when you shouldn't do it. And we came up with a risk assessment table that you can see. It's very summarized, but basically you look at different parameters, of course, the gingival margin position, the soft tissue quality, of course, you look at the bone anchorage, feasibility to place your implant in a proper position, of course, presence of facial bone, presence of infection, alveolar bone defects, and more specifically proximal bone defects. And what is also very important is this buccal gap, but we will see that with cases. And basically, when you are on the red zone, when you have a deep gingival recession, when you have a lack of bone anchorage, a large fenestration, descents, proximal loss, with a need of tissue augmentation. These are for me the red light and definitely the cases where we cannot reliably reach a good aesthetic outcome. It's not that it's impossible, but it's not going to be absolutely reliable. And I don't want to take any risk in the aesthetic zone. So basically, you know, here in the red, this is 3-case scenario. And this is 3-case scenario that I would like to illustrate tonight with 3 cases. So first, I come back to the green zone or the yellow zone. So basically, when the socket is intact, when we have no recession, when soft tissue phenotype is thick, these are the absolutely favorable conditions for immediate implants. When you have a little fenestration, you know, not too large, like 2-3 millimeters maximum, or a thin descents or limited descents, these are, you know, a little bit more risky. We know those cases will shrink more easily, and but you can mitigate the risk. And this is typically the cases where we can still do immediate implant, but we would probably work with a connective tissue graft, and we need to mitigate that risk. But this is not what I'm talking about today. What I'm talking about today is more those cases. And here, this is basically the outline of the 3 cases I want to share with you. One is, as you can see, as a deep recession. So a case like that, I would never go with immediate. Another one is the buccal bone is intact, but proximal loss. And proximal loss, this is really where it is going to be challenging. We will have to reconstruct, and it will take time, and I would not do it immediate. And the last case scenario is a buccal bone defect. So quite deep, you'll see, but the soft tissue are still okay. There is no recession, but still, when there is a significant buccal bone defect, these cases, according to what we know today and the evidence we have, it's still recommendable to do it in a delayed approach, or I mean, not immediate. And yeah, let's go through those cases, I would say. Yeah. So this first one, the case of yeah, this first case here, as you see, this is a deep recession. It's a recession of more than 2 millimeters. This is a little bit the threshold. And when you look at the aesthetic analysis, this is the case here I did with Amélie. I think you invited Amélie recently, right?
Yeah, Amelie also did a Just Ask with us. Very nice one on pros. And have a look into that Just Ask also. You'll see it in the YouTube channel.
Yeah. Yeah, Amelie and I, we're very complementary. We work together. I'm only doing the surgical aspect. She's doing the restorative, and this is a case here. She did an aesthetic analysis, and we see that, of course, we will have to gain some soft tissues on the number 11, but we could compensate and do a little crown lengthening, because that's always a way, doing crown lengthening to compensate and harmonize. We also see that we need some root coverage on the neighboring teeth. But this planning is, for me, this is super important, because it allows me to really identify the challenge. And here I see the papilla is not so much of a problem, but this is the recession. There is no proximal loss, so this is something favorable. And based on that, we build the treatment planning and we build the strategy.
I
So
mean,
this,
I sometimes see people doing immediate, they would augment soft tissue beforehand. Would that be an option for you to sort of do a recession coverage? Very difficult here because of deep crown margin. But would that be an option to improve the soft tissue beforehand and then go for immediate implant placement?
it's not my approach. I in a case like that, I think it would be probably too many efforts. You'll see. I mean, I'll have another approach, but I'm always open to, but
Got it.
it
Okay.
might not be the most straightforward.
Okay.
So here, because we had to redo also a crown on the neighboring teeth on the number 21, we worked with a little provisional with a cantilever. We cut Amélie actually placed that. She cut the roots, and she sent me the case. So the case starts with, of course, minimally invasive.
Franz, it's so interesting. Can I just have a question also? Did you cut the root on purpose to gain soft tissue?
Um, that was not the main purpose, but you see, this is actually a consequence of it. So you're right. But we did it because I wanted to
Okay.
have this bridge prior to my surgery.
Okay, good.
That was not the main goal, but it makes it a little bit easier. But anyway, to extract the tooth, I had to remove a little bit
Okay, got it.
overgrowing of the soft tissues. So minimally invasive extraction, and I mean, honestly, for me, this is a topic, minimally invasive extraction, because we talk a lot about immediate implant or alveolar ridge preservation, but one of the most important step is the way we do the extraction. And basically, the goal should be not touch at all the socket, the bone, and the remaining tissues you have, basically. So here, of course, you also check that your socket is intact. I mean, the rest of your socket, we know that we have a little bit of a buccal bone dehiscence, but that was still moderate in this case. I feel the socket. In this case, I don't use a membrane, and I covered with kind of a collagen sponge. So something very simple. Back then, I was also doing a connective tissue graft at that time, but I've stopped doing this because you'll see I prefer now to work with a connective tissue graft at the time of implant placement if necessary. So
What
this
is
is
the reason? Is that blood supply and the scarring a little bit more of the tissue?
I used to do a lot these saddled
Yeah,
connective tissue graft,
yeah.
and then you need a very long graft, and you
And it's
need.
also scarring, right? In the area where you have the open healing. Do you feel that
Yeah,
a
you
little bit?
can have a little scar, but
Mhm.
to avoid the scars, you need to properly remove
Yeah,
the intrasulcular or the junction
epithelium. Yeah.
epithelium. So I usually like to shave all this with a
Hmm.
diamond burr at the time of extraction, whether I do immediate or the alveolar ridge
Okay,
preservation.
got it.
And I just maintain, the collagen sponge with just a crust suture, nothing too fancy actually. So that's after the surgery, and then again, already from here, this is a restoratively driven soft tissue healing. Uh, it is the cervical level is a little bit lower than what it was on the planning, but this is very important. The shape of the pontic there has already an importance in my eyes. So you can see how this adapt, and this will support a little bit the papilla, and this will shape a little bit the tissues. And then this is how it is a few months later. So, and we see how the pontic is already organized, but most amazingly, we see how nature is well done, and soft tissue, they come back and they regenerate actually very, very nicely. And what will dictate that is actually the palatal level of your soft tissues. What is if you have a palatal level that is very coronal, then it's a good sign. And now we are already in a very good condition to actually place the implant. So then here it's time of the planning. So based on this planning, of course, there is a proper setup that is validated. We discussed that. And you see here the CBCT. So we had quite a large uh,
Canal.
canal here, but I work with this implant. If necessary, I can always remove. I mean, um, close it do a regeneration in this canal. This is something we can easily done, but then I need to do a flap, and that's not my goal. So here I decided to work with a narrow diameter implant. But this planning phase is absolutely important because three-dimensional implant position is really super important for the aesthetic outcome. So here it's not only about the implant placement, it's first having the proper setup, the proper design according to, you see, this is really according to the aesthetic planning that was done at the very beginning. So here we increase a little bit at the cervical level. So based on that, I will place my implant, but I will also place the component and the transmucosal component, whether you use a base or here this is a variobase. Now I always choose something that is as narrow as possible and as high as possible, at least 2.5 millimeter. We know now how the emergence profile is important. We want to have something narrow to leave more space for the living tissues. And then we have, the profile going through the cervical level and with a little bit of an horizontal component. We want a nice profile. But it's really something we need to spend time on, this planning, implant positioning, vertical positioning. And based on that, this is then here a guided surgery, with a static guide. But if I go to the next slide here, actually the crown, the provisional crown, as you see, and is designed and is actually performed prior to the surgery. So I receive this from the lab prior to the surgery. This is a technique I very, very much like, and we actually collected quite some data. It's very reliable. It's half of the time this is perfect, and the other half of the time you may have a little discrepancy, but which is not harmful. This is always possible to place a crown, and this is very minor. Yeah, again, you see the design, and this is very important to have the proper profile that will guide again the soft tissue healing, even if we don't do immediate in this case.
Franz, in these cases of socket and ridge preservation, you alluded to the narrow situation of the transmucosal component. Um, how deep do you place the implant in this situation? Because I sometimes have the feeling that, in particular in these augmented cases, you may have to go a little deeper because it's not a completely structured bone, it's not a completely mature bone. Are you compensating for that, or do you place it at equal height as you would do in a native bone?
Mhm. Thank you very much for the question, because this is a very, very important topic. And actually, this is not so much related to the bone or where is the bone, and it's really related to the aesthetic planning. What we want, we know where we want the cervical level, and everything is about that. So we know that from a biological point of view, we want to have 3 to 4 millimeters. That's the biological need. But then there are the prosthetic needs. So this is why, and some colleagues, they describe the biorestorative implant planning, which take into account not only the tissues and the bone, but we start from the restorative aspects, but we take into account the all, the soft tissues, the bone, and I always want to have this 2.5 millimeter of the faria base, and then I want to have a smooth transition to the cervical level.
Yeah.
And in the aesthetic zone like that, for a central incisor, usually we often 5 millimeter.
Okay, got it.
Cervical level, if I need to give a number.
Yeah.
So once the implant is placed, in this case, I did a small connective tissue graft because I wanted to compensate a little bit the shrinkage we got. Even though we did do an alveolar ridge preservation, we have a shrinkage, and you were the one demonstrating already now a long time ago that we have post-extractional remodeling. And at the same time, I did this little crown lengthening on the 21. So to have only one surgery here, this is a gingivectomy combined to a little osteoplasty. So this is why I did a little flap to recreate the biological space on this one. And then directly after, I placed the provisional that was prefabricated, and the Amélie also relined, and the contralateral. So this is right after the surgery, and this is typically here a soft tissue, a prosthetically or restoratively driven soft tissue healing. And this is how it is after, I think, 1 or 2 weeks at suture removal. And we see that the tissues, they take their space. And look, I go back, you see, even the papilla is not completely filled here. It is already better here. And this is here after, this is still the provisionals here. This is after, I think here, just 2 months. And we see that the healing really follows the provisionals. Yeah, this is where we are now, but even though we don't have yet the final, we're really on the way for very good aesthetic results. Of course, I have still to graft the posterior regions and the canine, but yeah, delayed.
Great result. Great result. There's a question from Mayor Tal, but I think you will allude to that later about the grafting material. I think you will also, in one of your later cases, talk about that, right? We can move that
absolutely.
on.
Mm-hmm.
Okay, perfect. Let's look at your second case. I'm really eager.
Okay, let's go to the next case. So the next case is this one.
That is a challenging one.
This one, obviously, you can see we have a papilla loss, so we have a proximal soft tissue defect that usually goes with a proximal bone loss. And again, these are cases where I would not favor an immediate implant placement, because for me this is just not fully not at all reliable. So, and this is, these proximal loss, this is really considered as a high risk even if it's on one side or the other, but in this case, it was on both sides of the central incisor, even though the buccal bone wall is intact, and but even worse if the buccal bone wall is actually compromised as well. So again, that would be my, I would never extract a tooth without trying to preserve what I can preserve. And here it's a very similar scenario. So this is a xenograft here. I'll discuss the xenograft, I think for this case or the next case. Collagen plug and a little suture. And and this is how it is after a few months. So in this case, yeah, you see here how it heals. This is a case, and I showed you actually, we see the bone here, but we also here see the socket that was filled with the material, and we see how good it is. But you preserve only what was in the socket. Yeah. And in this case, there was actually the anatomy, the roots, they were protruding actually outside the bone envelope. So in this case, I had to augment the bone as well, even though I did an alveolar ridge preservation. But we see also, this is nice to see the biomaterial that is now slowly resorbable here by transparency, and we still see the former sockets. So after that's where I want to hit the material. So that was a good moment. So we want something actually biocompatible, of course, in terms of biomaterial selection. We don't want to have an inflammatory reaction or foreign body reaction. That makes sense. We want something that is osteoconductive, so something that will guide the bone healing. And if we look, for example, here we worked a lot with also with some of my colleagues on the effect of the biomaterial surface topography on and the biological effect and the effect on osseointegration. And here you have, for example, 4-hydroxyapatite. So chemically this is the same, but different manufacturing process. And the manufacturing process, and particularly the heat, the sintering process, really closes the micropores of the natural xenograft, or if this is a synthetic hydroxyapatite, this also melts. This is ceramic, and when you put it at high temperature, it melts. And we see from those histologic images that when the microporosities are preserved, you have much more bone around the particles. Basically, the particles are much more, there is more bone to material contact, like you have the bone to implant contact, you have the bone to material contact. And it is, in my opinion, important to have a material that fully integrates into the regenerated bone. So that's for osteoconductivity. And then non-resorbable or slowly resorbable. This is here actually a CBCT that was taken 10 years after an immediate implant. And the buccal bone gap was filled with a xenograft. And we see still the former socket, basically. What we want, and the only reason we want to use this material is to keep the volume. We know that these materials, they do not help the healing, really. I mean, a socket heals by itself, but we want to have the material to really keep the three-dimensional dimensions and volume over the long term. So that's why
France, you're an expert in that bone particles and healing. Can you give a comment to the people saying with hydroxyapatite, you have residual particles? I mean, you showed it after 10 years. We have biopsies from the sinus after 20 years. For some people, this is a concern to have residual particles. They say this is an area where there is no vital bone. It might be a problem when there's an infection. Can you allude to that? I'm 100% on your side, but you know what some of the people say.
But first of all, it's important to understand that when you place an implant in a regenerated bone with a non-resorbable material, you will never have a direct contact of the particle with the implant. You always have like first a blood clot, but then bone regeneration or other type of tissues in between. So you never have a direct contact. When it comes to, you know, the evidence of the literature now shows that there is no more risk of peri-implantitis in regenerated bone than in pristine bone. So this was the concern for many people, but now we have this evidence, and this was never one of my concern. And there is, I mean, this is still a very vascular bone. You know, we have blood vessels in between. It's just a composite. You know, it's a regenerated composite, but that allows really the stability on the long run.
Very clear. Thank you.
Okay, let's go back to our case. So this is how it is here. But after here, alveolar ridge preservation, but also augmentation. And you know, of course, again, from the aesthetic analysis and from the planning, I do my implant positioning exactly the same way, you know, based on the prosthetic design, placing the implant, but also placing the transmucosal abutment, and the transmucosal abutment will really help me positioning the implant vertically. We want to have at least 1.5 millimeters buccally. This is the buccal shield, I would say. And of course, we also choose the implant diameter and length accordingly. We'll see from the clinical picture that this is pretty flat. Here, clearly, the papilla are going to be a challenge, and I know that since the very beginning. And here are the sequence. So I place the implant with a guide again. I already, you know, I did it here in the flapless approach. I already did a small connective tissue graft in the area of the papilla to try boosting it a little bit. Again, the prosthetic here will help the tissue healing. And this is something I didn't show here, the aesthetic analysis, but here we will, our plan is also to compensate a little bit with a crown lengthening. And that's a little bit a way in these complex cases to trick and go for teeth that are a bit higher to try to recreate this papilla. So this is how it healed after implant placement, but I was not fully happy. So I actually redesigned the provisional, and here, you know, again, the importance of the design, and did a more significant soft tissue augmentation here, first buccally with connective tissue graft and 2 little iceberg. I tried to do it in a tunnel approach, placing those little iceberg under the papilla and release the soft tissue vertically. But you know, that's the vertical, that's the proximal loss. Huh? This is easy. This is not easy cases. This is challenging cases. And even though, you know, we can also say here that we will not be able to compensate everything on the first quadrant. So the goal was also to do this little crown lengthening, and you see here I do the gingivectomy here with a little laser, but I also open a flap to re-establish the biological width and do a little osteoplasty. I usually prefer to do that with a real flap than flapless, because I like to visualize the bone. And then after a few months, my colleague, this is my colleague Damian Scheiner, did the final work, the final restorative. And we see here, this is not perfect, but we could reestablish the harmony. Yeah, with crown lengthening on one side, bone reconstruction on the other side. And I also always ask them, leave this little papilla open, because we have a connective tissue graft underneath, and usually after months and years, they tend to grow. So I have a
And
good.
Franz, this is so difficult to tell this the lab technicians. I tell them all the time, but they always want to close it. So I think it's a very important message from you. Leave it open. There will be tissue growing into that if you have, in particular, if you have augmented it.
Yeah, exactly. I mean, sometimes we have the opposite reaction. We have overgrowth with connective tissue graft, and this is why we sometimes should not graft
Right.
too much. But typically in this case, I mean, for papillas, I mean, I like to have a good connective tissue and leave it open, and I'm pretty sure in 1 year from now this will be filled.
Yeah. Perfect. Wonderful. Wow. Looking forward to your third case.
Okay, let's go to the next one. And the next one is the last one. And this is an old case, actually. This is an old case. I have quite a lot of follow-up, but I like it because you see, this is actually a patient that was sent to me, and you see this is a little bit in a healing phase. Actually, the dentist opened the flap, and he saw a failure and didn't want to extract the tooth. And actually, I like it because for me, this is easier to manage when I receive the case and the tooth is still on, it's not everything is gone already. So it's good because after careful extraction, this is a case where here, I take my finger, I take the probe, and there you see that you have like a very huge buccal defect. I expected that from the history and from what the referring dentist told me. And for me, this is a case. First of all, you cannot do like a traditional alveolar ridge preservation because here the wall is open all the way. So if you just put the material, you would just have a fibro integration of the material, and you will not have bone regeneration because the socket, when it's not intact, there is like soft tissue in growth. And in those cases, I do a full thickness flap. So you see this is the defect. I still have some little peaks of bone, but actually this is very wide and very deep until the apex of the tooth. So in these cases, what I did, and I like to still preserve, it's still an alveolar ridge preservation, but with a membrane and with a full thickness flap. And this is basically a GBR at the time of extraction that I treated here again with the Xeno and the collagen membrane. And here I did a little vertical release distally because the defect was actually quite deep. And then there, of course, I could try to do a release incision, close the flap, but in this case, I did a saddle connective tissue graft. I'm not sure if I would still do that today, because I prefer to do that at the time of implant placement. But if I also try not to leave too much of the collagen membrane exposed. If I have a little bit, this is okay, but I would not. Then I try to have a little bit more of a first intention healing. But at that time, I did this saddle connective tissue graft. This is how it was after the surgery, and yeah, and this is here after. Here I waited probably a bit more. I was probably 4-5 months, but it's old. It was not even CBCT at that time. It was the scanner, but I have preserved quite well the graft. This is an implant placement here. at that time it was not guided surgery, and we can of course today I would do a guided surgery, especially I did a flapless approach, but this case I think has now more than 15 years. So but this is interesting because we also see the follow-up. So this is here with the provisional, and we see here that we have actually a very nice integration of the provisional, the soft tissues. We see a little bit of a scar, but we can almost see, you know, the former cervical level. This is what you were mentioning maybe before. Yeah, we may have that, and to decrease the risk of having these type of scars, it's really removing the trans mucosal epithelium with a burr. I like to do it with a diamond burr. And yeah, we have here the final crown that was done by the restorative dentist. She also did a veneer on the neighboring teeth. And here, this is already the result after 3 years. The patient was quite happy. It was a nicely integrated smile. Nice work of the ceramist. And yeah, and then I saw the patient 10 years later. And yeah, so I think in terms of soft tissues, this is definitely very stable, and we can even see a little increase of the grafted tissue. So this is very typical. Obviously, we can also see another downside of implants, but I think it's nice to mention. And I have to say that now that I'm seeing those, you know, 10, 15 years follow-up of all these aesthetic cases I did, 10, 15 years ago, this is not unusual to see these facial grown, which we can treat in different ways. We can redo a crown, we can, this is usually minor, and this patient was implanted. She was like 35 or something like that. It was not she was not a young adult. And in this case, the way we did, because the crown was nicely integrated, we actually did some ortho with aligners, as you can see. Still, she has the attachment. It's not yet fully finished there. But yeah, basically we worked with reintrusion of the neighboring teeth. And yeah, this we can also now, how can we avoid that? But it's another topic. Maybe this is another topic for another Just Ask session.
Yeah.
But yeah, what I wanted to show here is the long-term outcome of these procedures with alveolar ridge preservation, in this case with a membrane, because there was a large defect. And I'd like to finish this case with some data we have collected now a few years ago, and I think it was one of the first study from our group, and first study showing long-term data about alveolar ridge preservation, and it's one of my former postgrad student that collected all this data. And what we could show early on, that we had about this 1 millimeter of bone remodeling from baseline to 3 months. You know, we can limit the post-extractional bone remodeling, but not totally. And in average, we have like a resorption of 1 millimeter buccally. But then what we show is that on the long term, I mean, 6 years, 7 years, we can already consider long term. From 3 months to 6 years, we have an additional remodeling of 0.07 millimeter. So basically 0. It is very stable. So yeah, now I think we have more and more data about long-term volume stability when doing alveolar ridge preservation, and particularly with no slowly resorbable material. And that was important for me to mention this this data.
Great study. Very nice, Franz. Amazing cases. I think that was it, right? That was your presentation. Or did you have a conclusion? Sorry.
I have a few key messages, but you know,
Okay.
let's conclude maybe, discussing together.
Yeah, that would be nice. So it was amazing. I loved your cases, and the people here in the chat, they also love your cases. And there are a lot little there are a lot of questions, and I want to, at least we are a little over the time already, but I want to hand over some of the questions to you. There's one question which I like very much from Stefan. He wants to know about this pontic design because you alluded to that a little bit. It's important how you put the pontic at the time of tooth extraction um, and socket preservation. Can you elaborate on that a little bit?
There are actually different strategies, I think, on how really to design the pontic. Uh, I don't know if the question is about exactly which design, but what I want is whether, even if I have a connective tissue graft on the surgery, I want to have something that will emerge naturally. So I don't want to have something avoid totally compressive, but I want something that touches the tissues definitely, and have is idealized
So you
as
don't
we.
want to have a gap because
No,
I
no, no,
learned
no.
it in my oral surgery things. You have to look through it because you will see swelling, and you remember that, right? That is wrong.
No, yeah. I mean, I think we should really take advantage of the surgery and of this transient inflammation, and we have a transient plasticity of the tissue. So we want to have something that is just right, not super compressive, but something that will support and guide the tissue. So and the connective tissue or the tissues will just heal around it. So
Yeah.
um, clearly not away from the graft or clearly not away from the tissues.
Got it. There's an interesting question from Mertal. We didn't allude to that, but maybe just two sentences about partial extraction therapy or socket shielding. Is that anything which is in your portfolio, or don't you use it? We also had just asked on that with Howie Gluckman.
So, but that's very good. And well, I don't have lots of experience
Mhm.
with partial extraction therapy. I mean, for me, this is, you need to have the right indications. I think it's brilliant in terms of biology. And but I have to say that I don't have experience with that. But I want to take the opportunity to tell you that uh, at in Lisbon, EAO Lisbon, in September, I will have the big honor to actually share co-share session on dedicated to immediate implant. And we don't want to redo the whole story about immediate implant, but we want to hit some very specific topic. And we will have Sonia Lazy. She has a
Mhm.
huge experience with partial extraction therapy. And,
Yes.
I would just tell the guests to just come to Lisbon.
Yeah, go there. Or watch the Just Ask with Howie Gluckman, also one of the big shots in partial extraction therapy. And by the way, there's an early bird rate for Lisbon until 25th of June. So it will be a little bit cheaper to see all the big names.
Yeah.
There's one question, I think we alluded to that. Maybe just very quickly is how do you secure the graft when you do like an implant placement? Here, Kavira wants to know how can you suture it? You want to suture it on the bone? Obviously not, but you want to place the implant on the bone and then you put a connective tissue graft. How do you suture that? That's the question.
Uh, when when I implant a case, I mean, depending if I do a flap or not. I mean, here I've talked mainly about delayed implant. So, or I do like a small mini flap where I just suture the connective tissue graft inside the flap. Um, yeah, but
Okay.
you want to cover completely the connective tissue
Yeah.
graft.
There's also one interesting question from Daniele. I think he asked that also by my introductory case. What about orthodontic extrusion? Do you sometimes think of that, or is that something which you don't have in your portfolio?
Yeah. I love working with orthodontists. I really like
We
that.
saw
And
that in your last case. Mm.
And but in your case, the case you started with, I think it could be smart because you had these infra bony defect, And it could have, yeah, it could be definitely a good treatment option or strategy to rebuild proximally the bone. Yeah.
On the other
Yeah.
hand, you also see how nicely nature sometimes works, right? When you take out the tooth and guide the soft tissue, as I saw it in your cases. So it's a little bit double-sided. Yeah, that's it. There's one more question. Maybe you allude to that. There's a question on fillers. Are you using fillers to pump up papillas or grow up tissue? Is that something which you do?
Yeah, like some hyaluronic acid or injections, things like that. The thing is, answer is no, I don't, but I can say why. Papilla, I mean, is a very fibrous tissue. You know, it doesn't expand. It's not like the alveolar mucosa, so it doesn't distend. So the few studies we have about, and they're now quite old, about injecting hyaluronic acid, I mean, honestly, this is like baby steps, but because of that, because the tissue cannot really, has no expansion capacities. And also this is just you know, you need to do that every 6 months or every year, so that's also quite invasive,
Great
I would.
point. Franz, that was amazing. The people applaud you in the chat. They love your cases. They say fantastic results, amazing cases. I say the same. Amazing work that you do. But I knew that. We know each other for 20 years, and you already had these great cases 20 years ago. I don't know how you do it. So congratulations to your work, congratulations to your cases, and congratulations to the nice way you presented everything. It was so great to do that with you. With that, Franz, I want to leave you to your Belgian football team. I just looked up the score. I think they need your support. It doesn't look that good. Uh, so quickly go to the TV and support the Belgium. With that, I say good night to everyone all around. Thank you also from behalf of the EAO, from the EAO board. Please, everyone, come to Lisbon. You will see Franz. You can ask her all the questions. With that, ciao, ciao. Good night. Thank you again,
Thank you
Franz.
so
Ciao,
much,
all around.
Stefan.
Ciao.
It was so great to have
Yeah.
you. Yeah,
Ciao, ciao,
bye.
ciao.
Ciao. Thank you so
Wonderful.
much.